everyone. My name is Davis from Cardiovisual. We are a patient education platform providing free educational videos around heart health, diabetes, and wellness. So make sure to check us out at heart.medicalvisual.com and diabetes.medicalvisual.com. I'm super excited to be joined with Mike Carunchio from OK Medic podcast and Dr. Sush Prusty from My Heart MD to provide you this talk on the critical moments from home to hospital, a paramedic's perspective on pre-hospital stroke care. This is part one of our series leading up to World Stroke Day on October 29th, so stay tuned for information regarding that. And we are very thankful to Dr. Sush Prusty for his collaboration in providing this live series. For background on him, he is a board-certified emergency physician with over 20 years of experience practicing in Boston. And as a former U.S. military flight surgeon, Dr. Prusty has a unique experience in high-pressure medical environments. He is also a highly respected medical educator, specializing in emergency medicine, cardiovascular disease, and ECG interpretation. So make sure to check him out on his page. Known for delivering award-winning lectures, Dr. Prusty is committed to teaching and mentoring the next generation of medical professionals. And with that, I welcome you, Sush. Hello.
Davis, good evening, and how are you doing?
I'm doing well. How are you?
I'm doing great, thanks. And you make me sound something that I'm maybe, I don't know, I'm just a doctor. But thank you for that introduction, and folks, thanks so much for being here today. This is a huge subject, great interest. And so we are so thankful to Cardiovisual and to our colleague Mike Carunchio to join us today. Davis, shall we bring Mike on?
We shall, and I'll leave you two to discuss.
All right. Mike.
Hello, Sush.
How you doing, my friend?
Phenomenal. I'm getting ready to go in for a night shift in a little bit. So,
all right. So you are going to do what you want to do. You love doing. We really appreciate it. Thanks for what you do.
Thanks for having me.
Yeah, my pleasure. Guys, this is a sort of a lead up to the next Tuesday's big event with Dr. Gurkalgi on strokes and cardiovascular disease, obesity, AFib, stroke. It's all sort of connected, right? So we thought we'd bring in Mike Carunchio. Why is Mike so important to this? The reason is that strokes present outside the hospital. And the people who see providers, are the people who see Mike Carunchio first. So Mike, we're going to get into this right now. You are so kind to give us a great case this morning. Case 278. Let's get into this case and see what people thought. Davis, thank you so much for sharing this. This was an ECG that Mike you got, but before we get into the ECG, Mike, tell us when you got to this patient, right? Tell us more about it. I want to hear about how the call came in. I want to hear about what your knee-jerk sort of gut reaction was, and we'll go from there.
Well, it was initially dispatched as a stroke, and I may sound negative here, but that means nothing to me when I get dispatched for a stroke, because anybody that sneezes and twitches, our dispatch center will triage as a stroke. They just automatically, it's really not sensitive nor specific. So, but the dispatch notes were 68-year-old male, I believe, or 63. I think 68-year, it doesn't matter. Guy in his 60s. The call came in, acute onset dizziness. I thought, okay, maybe it's vertigo, maybe it's a stroke, maybe, who knows, maybe it's a blood pressure issue. And responded to his house. It was a beautiful fall morning. And when I arrived, we're a two-tier system. So I'm an advanced life support provider. So I'm in essentially a police car with medical equipment. I'm by myself. I responded to this guy's house. The ambulance from the fire company was there. And I see them walking this gentleman out. And He was a guy in his 60s. He was overweight. He wasn't morbidly obese, but he definitely was overweight. He was a big, tall, stocky, tough-looking guy. The type of guy that you wouldn't want to be in a bar fight with, because he looked like a strong working class laborer. And my initial thought was, there is something wrong with this man, because here's this burly, tough guy wearing a Philadelphia Eagles sweatshirt, and he's literally arm in arm linked up with the EMT, walking like they're prom dates, walking into the prom together as the EMTs are walking him to the stretcher. And this poor guy was walking like that because he couldn't walk straight. His gait was abnormal, and he just couldn't stay steady on his feet. And when I pulled up, my first intuition was, okay, this is probably legit, because here's this tough guy who needs a couple guys to help him walk out to the stretcher.
Mike.
Yes.
I want to stop you there.
Sure.
You're a pre-hospital provider. You're a clinician.
Yes.
We talk about differential diagnoses, and you've told me a few things already right now that tells me that your gears are turning.
Yes.
And, you know, in medicine, medical school, residency, we talk about differential diagnoses, and we go through a litany of things that this could be and not be. Pre-hospital medicine is different, isn't it, Mike?
It is a little down, dirtier, and less resources. You have to function.
Here's what I see. And in my world, in my job as a pre-hospital medical director, I see you folks having very little time in deciding what is sick and not sick. And one of the things I think about and I talk about is the subconscious differential. You've told me a few things already. You've painted this picture for me of a fellow who is not well, certainly, and has something going on in his brain.
Yes. And it could have been a lot of things. He could have been drunk. It could have been a stroke. It could have been vertigo. But just pulling up, I wasn't even out of my car yet, and I thought, there is something wrong with this guy's brain that is making him walk like this.
You saw him from your chase vehicle?
Yes. Yeah, I wasn't even out yet.
That's something else. Go ahead.
So made contact with him, and they really, I know we have a lot of international viewers on here. In the United States, pre-hospital stroke protocols are heavily geared to large vessel occlusions. And we have stroke scales in our stroke protocols. We use the Cincinnati score. We also use the M-RACE score where I work. And this guy did not meet any of those criteria. He did not have any facial droop. I guess if you're going by M-RACE and gait abnormality or lower limb function, he would have a low score, a 1. But that's really nothing to start like banging alarm bells about. But as far as Cincinnati, which is the one that we use predominantly in my area, he had no facial droop, his speech was crystal clear, and he had no hemiparesis or pronator drift.
And that is your stroke scale.
That's our stroke scale. So he passed all of those. He had crystal clear speech. His face was symmetric. His strength was symmetric. When he was on the stretcher and I asked him to move his legs and I tested for leg strengthness, it was equal, and he had great leg strength. His speech was crystal clear. He had no altered mental status. Small world in the Philadelphia area. His family and my family knew some similar people, so we had a completely cogent conversation about different people that we know. So there was no altered mental status, and he did not meet the stroke alert criteria. So that set off alarm bells for me even more, because here's this guy who clearly could not walk straight, but his neuro tests on the stretcher were all checking out. So it was the primary problem was ataxia, and he was telling me that he had this sensation that the room was spinning. The story with him was that he was making his morning coffee. He got up, was making coffee, and all of a sudden he said it was like just the room started spinning around him, and he wanted to take a couple steps, and he was able to take the steps, but he was so dizzy that he almost fell over, and his wife had to help him sit down on the couch. So that was the history. There was no headache. There was no prodrome. That was it.
What made you get an ECG, Mike?
I wish I had some really insightful thing to tell you that made me get it.
You just told me he had no symptoms.
Sure.
he has some dizziness, making coffee.
Sure.
You get an ECG on him.
Well,
What's going on with you?
of course, I'm going to get an ECG with him. But the reason I did an ECG on all my stroke patients, I wish I had some earth-shattering thing to tell you. But I've been doing this job for 23 years now, and when I started, where I was working, the protocols for stroke were perform and interpret 12-lead ECG, and it has just stuck. So I always do it on all my stroke patients, which is good practice.
It is good practice, and I think we can fact check this, but I think like 4 out of 5 or something like that, 20% of patients who have uncontrolled AFib are at risk for strokes, right?
And
so
when I saw the AFib, it wasn't even a 12-lead yet. When I put him on the monitor and I saw the AFib,
you saw it.
I thought to myself, this guy's got a clot somewhere in his posterior circulation.
Yeah. Something like that, right? And he had a history of dizziness for the past year, you said, right?
Yes. I can't remember if he had a history of AFib or not, but I do remember that he was not anticoagulated. He wasn't on Eliquis or Pradaxa, but he told me that he had some dizzy spells over the last year. And he noticed that they were seeming to get worse and longer in duration. He said about a week prior, he was doing work on his gutters and he got this really bad dizzy spell. And he said he clung to the ladder and he said, I just closed my eyes hoping it would pass. And he said, thank God it passed and I didn't fall off the ladder.
Right.
So I thought maybe he has vertigo. I kind of think with the AFib and the sudden onset, it's a stroke. But looking up after this call, he did, spoiler alert, he had a posterior infarct. Looking up after the call, patients with posterior cerebellar infarcts, many of them often, at least the literature says, many of them often report dizzy spells. And some authorities say that those should be considered to be TIAs in these patients.
Right. You are correct about that. As a matter of fact, I've had a colleague who said he treated a patient with vertigo with the Epton maneuver to fix it. And guess what? It got fixed. Not just once, but twice in the ER. Turned out the third visit turned out to be a stroke. Okay. So you are correct about that. Let's be mindful about this. Now, it's not common now. The literature does not say that recurring spells of intermittent self-resolving dizziness equals TIAs that could result in posterior strokes. The literature will not support that, and I'd agree with that. But when you hear of a history like this, we've got to be more aware, more alert about it, right? So, by the way, comment about here from one of our listeners about anticoagulation. The answer is no. The patient was not anticoagulated. The patient was well, so no anticoagulation, right, Mike?
Yeah, no anticoagulation. He was on an antihypertensive, I think, but his history certainly wasn't anything earth-shattering.
Right. Now, this talk, Mike, is about AFib. The connecting the dots, AFib, obesity, stroke. What was his body habitus like when you saw him?
He wasn't a morbidly obese guy, but he was a big Philadelphia dude. He was tall Irishman. He was stocky. He was strong. I think he was a laborer of some sort for his job. So he had that inherent strength from decades of working manual labor. But he also had a big beer belly that stuck out a good bit. So he certainly was. We respond to some very large patients, and I'm sure you see them in the ER. So by my gestalt, he was not morbidly obese, but if he went to a family medicine doctor, they would certainly tell him based on his BMI, sir, you're obese and need to lose weight.
Yeah, right. And how about alcohol use? Alcohol is known to be a contributor to AFib and things like that.
Sure. I asked him if he had anything to drink, certainly because of his ataxia, and also because he kind of looked ruddy in the face. And he told me he was a social drinker. He was not intoxicated at the time. I think he's the type of guy who drinks a bunch of beers on Sunday watching football, but he didn't come across as an alcoholic or anything like that.
But it was every day a Sunday, though.
This is always the question.
It is always the question. All right. Hey, listen, this sounds like a sick patient, Mike. And
He was concerning. I was really concerned about him.
And you've got your antennas up. You see him. You get a 12 lead. You see an ECG that shows AFib. You identify it, right?
Yes, which just helped me go more narrow down the stroke pathway as opposed to vertigo.
And there's the ECG up top, folks. If you see it, there's nothing really that alarming on this ECG except that there is AFib for sure, right?
Correct.
There's an irregular rhythm. I don't see any oscillations, no key waves. I don't see anything really that concerning.
Yeah.
Right. Is that what your thought was too, Mike, when you saw this patient?
Yeah. I saw AFib. I did a 12 lead, and I saw more AFib. There were no ST segment changes, no signs of anything glaringly bad that would make me think this is anything other than a heart with AFib.
All right. So let's jump to the management and disposition. What did you do next?
Well, there's really not much for us to do pre-hospitally because some places I've heard want to give aspirin to be safe, but we don't want to do that because what if he has a head bleed? What if he's bleeding into his head and that's causing these symptoms? We don't have the ability to do a CAT scan. There are mobile stroke units in the United States, but there's only 20 of them. Those are ambulances with a CAT scanner and all sorts of technology. They really don't exist for the most part. So the real thing was to take him to the appropriate hospital. And he wanted to go to a community hospital that is not, I think they're nominally some type of stroke center because, everyone gets a rubber stamp for being some type of stroke center. But it was a community hospital that didn't have the capability to definitively treat a stroke. So we could have taken him 30 minutes to that community hospital where he wanted to go. And what all patients say, that's where all my doctors are. But yeah, at 9 a.m. on a Sunday, they're all going to be there waiting for you in the ER. But, or we could have gone 45 minutes in the completely other direction to a comprehensive stroke center.
Let's stop there. You made a decision.
I did.
You saw this patient and you were concerned about it. And people who know my teaching know me I'm notorious, I'm infamous for this, right? I don't like med control dictating what you guys do. My tagline is what? You know this, trust the medic. Trust the medic. You called in and said what?
I did. Well, first, I recommended to him that he go to the comprehensive stroke center. I said, look, man, I don't know. I suspect you might be having a stroke, worst case scenario. So there's all sorts of things that could be wrong with you. You need more testing, but my gut tells me you might be having a stroke. And I said, I know all your doctors are at the community hospital, and that's the convenient place where your kids live near for them to go visit you. But let's take you to the stroke center. And I told him, I said, if you do have a stroke and you go to this community hospital, there's a very good chance, it's beautiful weather out, they're going to hear the word stroke and they're going to call a helicopter to send you to a stroke center. And you're going to get a $60,000 bill for that helicopter because that's the way it is in the United States. I said, let's cut out the middleman. Let's potentially save you a whole lot of money and headaches with insurance. And let's just take you to the appropriate hospital. And he was okay with that. So we start going to the stroke center. I called the ER at the stroke center and said, here's what I got. I think he's a pre-hospital stroke activation. And they told me, no, he doesn't meet LVO stroke criteria. He's not going to be a stroke alert.
Right. So there's my point, right? You see something, you took an action on that. And there's some disagreement with what you saw and what people interpreted that as, the receiving facility. How did you deal with that?
I said, screw it. He needs a CAT scan. He needs a stroke center. If I'm wrong, it won't be the first time I've been wrong. But I'm going to stick to my guns. I'm going to go talk to the ER doctor one-on-one when I get there and convey to him. I say him because it was a him that I talked to. There's tons of great female ER doctors where I work. They're rock stars. But I said, I'm going to find him. I'm going to talk to him. I'm going to bring him into the patient, be like, hey, here's what I'm thinking. Here's what I'm seeing. I know he doesn't technically meet LVO stroke alert criteria, but the alarm bells are pinging.
Yeah. Mike, good for you.
Yeah, thanks.
If I applaud you, if I was your medical director in this case, I would say, bravo, great job. I wasn't. And it goes back to my point where we really need to trust our pre-hospital fighters. Because why? Because you guys are the ones who see these strokes. Strokes don't happen in hospitals for the most part, right? They happen in homes. Mm-hmm. And we count on patients calling 911, right? We also count on our EMS colleagues to make the correct call without questioning them. And in this case, you made the right call. You took him to a comprehensive stroke center where he wanted to go to his own local, it might be a great hospital, but it wasn't the right place for him. So thank you.
Sure.
Great job. How did things work out for him?
It worked out great. The doctor that I spoke to was not rude or dismissive. Very nice conversation. I understood where he was coming from, because no, he did not, according to our protocols, meet a pre-hospital stroke alert criteria, because it wasn't an LVO. So we got to the ER. I actually knew the ER nurse. She was a paramedic. She was a paramedic for 30 years before I was born, and she's a nurse now. And she was the receiving nurse. And I said, this guy's having a posterior stroke. I said, I guarantee it. And I said, usually we bring the stretcher next to the bed and the patient shimmies over. And I didn't do that this time. I had the stretcher lowered, but I made him take a couple of steps to the stretcher so that she could see it. Now, granted, we were on either side of him, so it's not like he was on his own. Right. We were just going to let him fall over.
Right.
But she watched him take 2 steps, and she said, oh, yeah, totally. Something's going on. And she got the doctor. The doctor came in, and he got the ball rolling, and the guy got TPA within an hour.
TPA?
Oh, I'm sorry, TNK. I'm still so used to saying TPA from years of doing this.
Yeah, right. We have changed over, right? TPA, TNK. So, as a matter of fact, we had a great question. Somebody asked me on a DM for the case this morning, saying TPA, TNK, what's the difference is. We'll get into that later on in a response to that person, but not here.
A neurologist I know said there's all types of different data and literature on TNK versus TPA, but we're using TNK because it's cheaper.
There you go. That's the bottom line, right?
Yeah. So.
Right. So that's an important thing. It's a good perspective, and it is what it is.
But
right?
Yeah, he did. He got a CTA. It was a great time for him to go. This is one of the for years. This place was in the 10 busiest ERs in the United States. And it happened to be a Sunday morning. The ER was dead, so he went right to imaging. He ended up getting a CTA that showed an occlusion in his posterior circulation, and he got TNK. And I don't know how he did, but the nurse texted me later, and she said, great catch. He did have a posterior stroke.
Well, you did the right thing. Posterior stroke, you took him to the right place. He got TNK. He did well. That you know at least. Great job. And really, I wanted to thank you for bringing this case forward, because I'll tell you what, ER doctor for a long time is what I am. These are not easy. Posterior strokes are the most incredibly difficult things, because why? We really sweat it when we see dizzy patients, because it could be posterior strokes. I've seen my colleagues fail at this, and it's a nightmare when you do fail, because posterior strokes can be so detrimental, so disastrous. So thank you so much, Mike, for bringing this out. And remember, guys, there's a stroke that occurs every 40 seconds in the U.S. Every 40 seconds, someone in the U.S. has a stroke. It's an important thing to recognize. It is not a minor thing. It's kind of like, it's almost at the same rate as a heart attack, right? So it's a really important thing. Mike, tell me your message to our community For patients who think they might be having a stroke, they don't know for sure or not, what is your message?
Oh,
Do you have a message?
for the non-medical community,
Right.
I would call 911. I would not get in your car. I would not drive. I would not. We have tragically, my department, I work 7 days on, 7 days off. During my tour of 7 shifts, I have at least one patient who had a stroke and then said, "Oh no, I don't think it's a stroke." And they wait and they wait and they wait. And then they call and they're out of the window for medications. They may be able to do a thrombectomy in certain types of situations, but they're out of the window. And many of them have been like, "Oh my God, I should have called. I should have called." And like, yes, you should have. So if you think you're having a stroke, don't delay. Call 911. The worst that can happen is that you're inconvenienced for a day and you sit in the ER getting a bunch of tests done that end up showing nothing. But if you're having a stroke, they are really, really good. These neurologists and neurosurgeons and ER physicians have this down to a literal science. It's almost, my other job, I work as a flight paramedic, and we fly patients directly to neurointervention. And I would tell the general public that they are so efficient at treating strokes. It's almost like watching the line at a McDonald's. They're just so good at it. So don't delay. The quicker, the better. Don't try to be a hero. Don't get in the car, try to drive yourself, because if it's a bleeding type stroke, it very well could get worse. You could go unresponsive. You could have a seizure. Just call us. We'll show up and we'll take care of you, and we'll get you to where you need to be, to the right center.
To the right place. That's right. Mike, we're going to leave it at that. That's a great message to our public, our community, because that's the most important thing that people need to know. Call 911 to let you folks decide where to go. And with that, let's conclude. I'm going to turn it back to Davis, and we can.
Thank you both for this conversation. I think we got some questions, but we can go through those at a later date. But this was really informative. Again, great catch by you, Mike. It really does show what it's like in the field, the different considerations to make when assessing a patient. And we also are looking forward to continuing this conversation on October 29th for World Stroke Day. That's what this is leading up to spread the word about both just stroke awareness, but also stroke care. So with that, thank you everyone for joining, and thank you both Mike and Sush for having this conversation with us.
Perfect.
Thanks for tuning in.
Okay.
Have a good night.
You
All
too.
right. Good night now.
Right. Bye.
Bye-bye.